Everyone, and today our topic of discussion is the continuation of the previous lecture. In the previous lecture, we had discussed about uh, the functions which are controlled by different cortical and subcortical areas, as well as cerebellar and spinal cord areas. Spinal cord. We discussed the pathophysiology, we discussed the incidents, and in this one, of course, like we will go on to the clinical features of stroke. Talking about the clinical features, um, the clinical presentation of the stroke depends on the arterial territory, as I already told you. And like number one thing is the territory of the artery. Number second thing is the size of the lesion, and number third is uh, what kind of stroke it is. Either it's ischemic stroke or either it is hemorrhagic stroke, right? So of course, whenever a patient comes, the first thing which we do is the history, and then we go for the neurological examination. And I already had a lecture on neurological examination. Uh, so, and if you will open the diagnostic playlist, like you will found a neurology examination anyways. Okay, so you can watch that video as well. Though that is not meant for your class, but like still you can have that. So I had a neurological examination video uh, in the neurological playlist, right? So, guys, we were discussing yesterday, for example, someone who is presenting with unilateral motor deficit and higher cerebral function deficit, such as aphasia or neglect or visual field defect, usually uh, guide us towards the lesion in the cerebral cortex, okay, or the hemisphere, cerebral hemisphere, right? But someone who's presenting with ataxia, diplopia, vertigo, and bilateral weakness usually indicate the lesion in the brainstem or the cerebellum. So quite easy. It's not like so hard thing to remember. Like very very easy thing, right? So what I'm saying is someone who have hemi neglect or aphasia with unilateral weakness points towards cerebral cerebral hemisphere, right? Okay, and someone who had ataxia as well as diplopia. Now, why diplopia? Now, if you know from where the cranial nerves come out, it is from the brainstem, and they are the ones which are controlling the eye movements as well. And for example, like the sixth cranial nerve or the fourth cranial nerve, whenever they are gone, or vertigo. Remember, vertigo starts from V, and uh, vestibulobasilar circulation, which is the posterior circulation, starts from V as well, or bilateral weakness, right? Um, points towards uh, points towards brainstem lesion, right? Lesion means, of course, infarct or hemorrhage, hemorrhage, whatever. Brainstem or cerebellum, right? So brainstem or cerebellum. So now, of course, there are different combinations, and there are different stroke syndromes which we must know. Okay. Uh, so someone who have like reduced conscious level, or someone who is coming with coma or stupor, indicates a large volume lesion, especially in the cerebral hemisphere. Or, of course, like whenever it is affecting the reticular activating system, so the thing will be clear in that case as well. So simply we take the history, not just about the onset and everything. We check the risk factors also as hypertension, heart disease, diabetes mellitus, smoking, hyperlipidemias, okay, family history, contraceptive pills, obesity, alcohol, heavy alcohol drinking, aging, genetics, uh, family history as well. Okay. Now, why this thing is important? Again, referred back to the previous lecture. We already discussed the large artery stroke and the small artery stroke, and we had discussed like what hypertension do, what diabetes do, what these things do. So based on that thing, you can discuss or you can remember what I'm talking about. So of course, like examination, when you would know, like examination is just not the neurological examination. We also examine the heart. We examine the carotid arteries because there could be, um, you can say, bruise in the carotid arteries, which shows like there is atherosclerotic plaques in the carotid arteries, and they can break off and can go and block any of the arteries. So simply anything can be there. Infective endocarditis can be there. There is a tumor of the heart called as atrial myxoma can be there. There is something called as paradoxical embolism, which was my thesis topic in masters as well. When the foramen is still patent and the embolus can enter the systemic circulation through the veins, it could be a fat embolism, it could be air embolism. The patient may have some blood viscosity or hypercoagulability like polycythemia or things like this, right? So of course, like whenever we do, like we for sure keep in mind all these things, right? So I already discussed the blood circulation and the functionality of different parts of the brain. So of course, like based on that, we can simply remember, for example, uh, what are the different stroke syndromes can be there. Okay, so now this thing, of course, like if we have to talk about all the stroke syndromes, guys, like like 20 lectures are not enough. So that's why easy ways to go through a neuroanatomy, read about the circulation, read about the clinical features, functionality, like which part of the brain control which functions in the body, and then so anterior cerebral artery can be gone, middle cerebral artery can be gone, posterior cerebral artery can be blocked. Okay, uh, basilar artery can be blocked. One thing is called as pica. What is pica? Like PICA, posterior inferior cerebellar artery. There are other names for like the stroke which is caused by this one. One is called as lateral medullary syndrome, or the other name is Wallenberg syndrome. Okay, like these are the other names of the spica. And then there is medial medullary infarct as well. Okay, then there is lacunar. I show you lacunar arteries in the previous lecture. Lacunar infarcts as well. So of course, like all these one give different type of features, and now if you know these arteries are supplying with structures, you can easily understand what is the thing going on. By the way, there is a very 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 easy mnemonic, or if you want, like you can search something, write um, write down the brainstem rule of four. Okay, write down the brainstem rules of four. So when you will write down that, you are going to get a very 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 good explanation of this thing. Okay, brain stem rule of four. Okay, so uh, actually you can say it's a way of remembering the things. Okay, like clinically, simply like of course because there are a lot of nuclei. So what is the brainstem rule of four is that it is devised by a guy called as Peter Gates. He was Australian neurologist. Okay, in 2003. So uh, the rule number one, what he gave is like there are four cranial nerves from above pons. Okay, which means like two comes from the midbrain and two are basically outgrowth of the brain, the olfactory and the optic. And there are four cranial nerves which comes from the pons, and there is four cranial nerves which comes from the medulla oblongata, right? So the last four comes from medulla, the middle four come from the pons, and the top four comes from above pons. Okay, so this is rule number one. Rule number two says four cranial nerve motor nuclei are in midline. Okay, or you can say they are medially located, and these four are those that divide equally into 12, except cranial nerve 1 and 2. For example, 3 can be divided on 12, 4, 6, and 12. So these cranial nerve 3, cranial nerve 4, cranial nerve 6, and cranial nerve 12, their motor nuclei are in the midline. And there are four motor nuclei which are laterally located, which is cranial nerve 4, 5, sorry, cranial nerve 5, 7, um, 9, 10, and 11. Rule number 3 says there are four midline structures beginning with M. So what are these four midline structures which begin with M? Number one is motor pathway, which is the corticospinal tract. Number second is the medial lemniscus, which is the extension of the dorsal columns. Number third is medial longitudinal fasciculus. Number fourth is motor nucleus, which we have already discussed. And rule number four says that there are four laterals, four sides, or four lateral structures which begin with S. So S is for side, or simply which are laterally located. So their names start from S. Number one is spinocerebellar tract. Number second is spinothalamic tract. Number third is sensory nucleus of cranial nerve 5. And number fourth is sympathetic pathway, which causes uh, what you can say, which causes Horner syndrome. A very good way to find this thing out is you can open this website called as radio paedia.org/articles. Okay, slash it is rule dash of dash the dash brain stem. Okay, so this one is like the website which you can consult and you can see. Okay, and by the way, if you will, like, I cannot Google it because Google is blocked over here, but what I can do is like simply I can Bing that thing and I can show you the Bing results if you will give me just 1 minute. Rule of four brain. Yes, very nice diagram. This one is nice, but like a little clearer. Yes, this one a very complicated one. Okay, wait. I think this one is the best one. Okay, the brainstem rule of four, and of course, like here it is not clear, but you can search it down and you will find like what I'm talking about, right? So now, guys, like simply when anterior cerebral artery is gone, contralaterally there will be motor weakness or paresis affecting the legs more than the arms. There will be contralateral sensory loss, and there will be apathy, confusion, and poor judgment. And whenever MCA is gone, especially when MCA is blocked proximally, or you can say the main MCA is blocked, not the small one. So again, there will be contralateral weakness of or sensory loss of the face and arm. Like of course, like the weakness in the arm will be more than the leg, right? And there will be cortical sensory loss. They have contralateral hemianopia. If the dominant lobe is gone, aphasia will be there. If non-dominant lobe is gone, neglect will be there, and the eyes will be deviated towards the side of the lesion. Okay, towards the side of the lesion, like lesion means the one which is in the brain, or you can say the eyes will be deviated away from the side of the weakness. When the posterior cerebral artery is gone, remember guys, it is the one which is supplying the occipital lobe. So they have contralateral hemianopia. Now, midbrain findings will be there. Cranial nerve third and fourth are originated from the midbrain. They will be affected. Thalamus is supplied by this PCA as well. So there will be sensory loss, amnesia. If bilaterally PCA is gone, so of course, like the person will be blind because both of the lobes will be gone. When the basilar artery is the one which is gone, so there is impaired extraocular movements, of course, because the cranial nerves which are originating from pons as well as the midbrain, they are originating from this area. A very important thing to remember, they will be having nystagmus, which will be vertical. There will be meiosis. There could be hemi or quadriplegia. And the persons can be in locked-in syndrome. What is locked-in syndrome? I explained this thing before. And if you want to again know more about locked-in syndrome, you can open Diagnostic playlist and again watch a video saying disturbance of consciousness. These are the people who can still think, who can still have memories, who still have all the higher cortical functions intact, but they cannot move their any part of the body, so they are locked in themselves. Many of the people they can present in coma as well. Pica is interesting. By the way, I can include that pica thing over here just to uh, now. Uh, uh, the important thing now, which I wanted to talk about, sorry, Wallenberg syndrome. I read pica and they opened this thing. I'm sorry for this thing. Okay, now. Okay, this one. See, like if okay, you know what you can do. Uh, you can what I show you is the brainstem rule of four. So when you can remember that rule of four, you would know like where are the motor nuclei related, like located and whatever. Like so, posterior inferior cerebral artery is gone. So like this is the area which will be affected. So see like what will happen to the patients ipsilaterally as well as contralaterally. So simply like quickly, if I will tell you, these are the people who have ipsilateral ataxia, ipsilateral Horner syndrome because the sympathetic. See, it is lateral syndrome, lateral medullary syndrome. So the Horner, sympathetic chain is on S for sympathetic chain, S is for side, so it is on the side. They have reactive meiosis. They have ipsilateral facial loss, sensory loss. Okay, they have contralateral opposite side limb impairment of the pain and temperature sensation. They have nystagmus, vertigo, nausea, vomiting, which is the feature of vertebrobasilar infarct. Anyways, they present with dysphagia, dysarthria, and hiccups. So this is how they present with. And then there is medial medullary infarct. Now again, if you know the mnemonic, like the brainstem rules of four, so see what are the midline structures, okay, which are in the center. So of course, like medial medullary infarct occurs when there is anterior spinal artery occlusion. So they have contralateral hemiparesis with facial sparing. They have contralateral impaired proprioception and vibration. Sensation is gone. Why? Because the medial lemniscus is the one which is affected, as well as they have ipsilateral tongue weakness. And what is the lacunar infarct? I'd show you the small arteries which basically go and supply the deeper part of the brain. And here what I'm talking about is basically the internal capsule, which I showed you in the previous lecture. So in lacunar infarcts, what happens is like the deep hemispheric white matter is the one which is involved. So most of these are the penetrating branch of the MCA shown in the previous lecture, or which are coming from the circle of Willis or basilar artery. So whenever there is lacunar infarct, guys, depending on what part of the internal capsule is damaged, for example, when the posterior limb of the internal capsule is damaged, they present with pure motor hemiparesis contralaterally. When the thalamus is affected, so they present with pure sensory loss in the body. When the internal capsule and the front side of the pons is gone, they present with ipsilateral ataxia and leg paresis. And now there is one more syndrome called as dysarthria, clumsy hand syndrome. Dysarthria, clumsy hand syndrome occurs when there is the genu of internal capsule is the one which is gone. So they present with dysarthria because the name is dysarthria, clumsy hand syndrome. So basically they have dysarthria, they have facial weakness, they have dysphagia, and they have mild hand weakness and clumsiness. That's why it is called as dysarthria, clumsy hand syndrome. So of course, like these are the clinical features, and as I told you that uh, it's hard to give you all the what you can say clinical features of the stroke because no one can. Okay, so that's why neuroanatomy, understanding of neuroanatomy is very, very, very important. Okay, so now, guys, okay, I will teach you this like other than uh, talking about the investigation first. Rather, I will uh, uh, go for the management directly, right? So, um, sorry. Talking about the management directly, I'll be going for the management directly, and the management. Okay, what I will do because uh, I believe like I can. It will be better for you if you will listen to me and you would know about the management, right? And I'm scrolling it down just for you guys. Like if you want any stop at any slide, you can stop. Okay, so whenever it comes to the management of the stroke, of course, like we do go for investigations, of course. Okay, so basically, like quickly, you can say we judge like either the patient have ischemic stroke or hemorrhagic stroke. Okay, uh, for example, like someone who have atherosclerosis, maybe in physical examination you will found xanthelismas, which is a sign of increased cholesterol. Maybe you will found like diabetic history, hypertensive history. Maybe you'll found atrial fibrillation. Maybe you'll found infective endocarditis. Maybe you will found anything, right? Like again, which is like the causes of stroke, right? So of course, like the first and the most important investigation which we do is for sure. Um, I explained all this things yesterday, right? Watershed area and all this stuff, and Numbra and all this stuff, right? So CT scan or MRI are the best investigations. Okay, no matter if it is hemorrhagic stroke or ischemic stroke, right? We go for CT scan. Just one important difference is what uh, if it's a subarachnoid hemorrhage, then we don't go for. Uh, we can go for CT scan, but like we can do lumbar puncture as well, right? So that's important thing. Um, of course, like there is a lot of investigations you can do. ECG to look for atrial fibrillation. You can do duplex ultrasound of carotids to look for like if there is any thing you found in the carotids. You can do CT angiography to see like where is a blockage. You can do contrast angiography. You can do CBC. You can do cholesterol levels. You can do blood glucose levels. You can do ESR. You can do echocardiography. Okay, so of course, like investigations are many because causes are many, simply, right? So, but like our discussion would be more like how to manage acute stroke, right? Okay, and I would like to stop here because I would be talking uh, more about these imagings from now on. Okay, and how we can what you can say differentiate between what's going on with the patient, right? So simply investigations are many. We do take history, we do examination, and we do investigations, and then we go for the management, right? So management is basically aimed at minimizing the volume of uh, the loss, okay, which is done to the brain. Uh, Simply, there is a lot of collateral circulation in the brain, so, our aim is to increase uh, the oxygen supply to the brain, of course, in order to minimize the loss. Okay, why? Because it will uh, prevent what you can say more loss to the brain, and the permanent disability to the person will be less, right? So any patient, guys, who is coming to the hospital, uh, the confirmation can be done by CT scan. Okay, and of course, like on the CT scan, because the most important thing is simply to see either the patient is having ischemic stroke uh, or what you can say hemorrhagic stroke. So now, uh, anyone who presents with stroke, okay, uh, of course, like we transfer them to the stroke center where all the facilities are available. Okay, there are many complications which can occur. For example, seizures can occur. Okay, uh, and like whenever seizures can occur, most of the time it is in hemorrhagic stroke. And of course, there is a lot of differential diagnosis of stroke as well, because there are many things which mimic or which seems like stroke. For example, uh, drug intoxications, infections, seizures, tumors, um, cerebral venous thrombosis, though it is not so common, but it should be kept in the mind as a differential diagnosis. Okay, when you are dealing with a stroke patient. And one bad thing is what? that 20 to 40% of the patients with ischemic stroke, they may develop hemorrhagic transformation within 1 week. So, for example, if you are seeing some patient, if you have 100 patients today who have ischemic stroke, maybe within 1 week, out of that 100, 20 to 40 patients will develop a secondary hemorrhagic stroke. Okay. So, uh, uh, now the important thing is there is fast screening. Okay, there are different, what you can say, scales are available. For example, one scale is called as the National Institute of Health Stroke Scale, NIHSS. So again, this is a scoring system. Okay, this is a scale which uses 11 items. Okay, uh, that evaluate the level of consciousness, visual system, motor system, sensory system, and language abilities. So the scoring is basically out of 42. So if the number is 0, so of course there is no stroke. If the number is 1 to 4, there is mild stroke, 5 to 15, moderate stroke, and 21 to 42 is like severe stroke. But of course, like uh, there is something called as aspect score as well. Like this is a 10-point scoring system which we used when we are assessing the CT scan of the patient. By the way, you don't have to go in these details right now because I will be talking about the acute management of the stroke. So first of all, the patient came and uh, according to the patient history, okay, the patient can present in coma, the patient can present with disturbance in level of consciousness, the patient can present with um, all alert, completely alert. Okay, depending on how the patient present, of course, your approach will be in that way. Okay, so the first thing in any case should be ABC, which is airway, breathing, and circulation, and of course, like we take the vital signs, we check the fever, uh, we check the temperature, we check the heart rate, we check the oxygen saturation, we check the blood pressure, uh, take bloods, go for blood sugar levels urgently. Hypoglycemia can mimic stroke. Okay. Now, one of the important thing is um, the first 4.5 hours, 4 hours and 30 minutes are very crucial, and they are considered as the golden hours because most common type of stroke is ischemic stroke, and if we can perform thrombolysis, like which is bursting up the thrombus, we can decrease the mortality as well as the morbidity. Okay, of course there is a lot of contraindications to thrombolytic therapy. Okay, so of course, like you had done ABC, you have checked the level of consciousness, you had checked like either there is any problem with the gaze, visual fields, either there is any facial palsies there, either there is any leg weakness, any arm weakness, any ataxia, any neglect, any aphasia, any sensation problems, right? Like you have checked this thing. Quickly, you will go for the history. You will ask like the time when um, he was symptom free, right? And you will see like how many hours are gone, and you will rule out any hypoglycemia, migraine, or anything like this. So the first investigation you will be ordering is this one, CT scan. And what we order is a non-contrast CT scan. And why we order CT scan? Just because of one thing. The most important thing why we are ordering CT scan is to rule out hemorrhage. Okay. we want to rule out hemorrhage, or if it is not hemorrhage, we can know what is the um, area which is infarcted. Okay, now the CT scan in the early hours can come back as normal in the case of infarction, not in the case of hemorrhage. But later on, you can see this hypotenuse area. Hypotenuse area. Okay, we can appreciate that hypotenuse area clearly on CT scan. Okay, so there is expect scoring, which we use. Okay, and of course, like this one is like the MRIs, but like we go for non-contrast CT scan, the first and the very important investigation. Uh, Quickly, you can do a ECG to rule out atrial fibrillation. You can do carotid Dopplers. You can do echo to rule out infective endocarditis. You can do CBC. You can do electrolytes. You can do creatinine. You can do coagulation profile and lipid profile. Uh, Remember that the infarcted area of the brain tissue can often appear normal on CT scan in the first few hours after the onset of stroke. And blood workup should only delay treatment if the patient is on anticoagulants. Otherwise, don't wait for the blood reports. Okay. So that's a very, very, very important thing. So we can see this hypodense area. Uh, we can see like there is a loss of gray white differentiation over here. Here you can see like the differentiation between the gray and white matter. Okay. So yeah, this thing is important. Now, guys, the most important thing is in I'm talking about now. Now I am talking about if it's a infarction, if it's a ischemic stroke. This one is the very, very important thing which you can do to the patient, right? The window time is less than 4.5 hours, as I told you. And our target is to restore the blood supply to the penumbra. And I told you what is that. This is the area which can be saved. Okay. Now the most important thing is the contraindications to thrombolytic therapy. How we do this treatment is the thrombolysis treatment is simply uh, by recombinant tissue plasminogen activator. Okay, so rtPA, recombinant tissue plasmin activator. It is most effective as urokinase. It breaks the clots. That's why it is called as thrombolytic. Okay. Now the important thing is the contraindications. Okay, guys, anyone who have mass infarction, high BP, heart attack, okay, or cardiac attack, or diabetes. By the way, uh, I will show you a better what you can say. Uh, contra Contraindications for thrombolysis. Okay, very, very, very important things, guys. Like this is important thing to remember. Okay, you can see like here, anyone who have prior intracerebral hemorrhage, any known intracranial malformation, ischemic stroke less than 3 months, suspected dissection, recent surgery, recent head trauma, bleeding, diathesis, and then there are relative contraindications, right? So now again, of course, like different books have, all the books have this thing, right? You can see over here, all like more or less all of them they are same. We quickly check the contraindications to thrombolytic therapy. If there is no contraindication, go for that. This is the best thing we can do. And once we are done with that, then we go for anti-platelet therapy. Okay. Okay, anticoagulants or antiplatelet therapy. I'm talking about antiplatelet therapy. So, indication for TI or prophylaxis, like the agents we use is like aspirin. We can use clopidogrel or ticlopidine. Okay, uh, guys, the important thing to remember about this one: antiplatelet agents should only be given if if rtPA not received. Okay, very important point. This is a very important point. Otherwise, we don't give that. Okay, so this thing uh, we can give them anticoagulant. See what we don't want the more and more thrombus to form. So uh, basically, anticoagulant therapy is mostly given to the patients who have TIA or stroke and atrial fibrillation. And again, uh, I will add the same point. If rtPA uh, not received, okay, very important, not received. Okay, so again the same point, guys. So we can use again IV heparin or low molecular weight heparin, okay, and initiate this thing very soon, okay, of course. So this thing defibrase, stop the enlargement of the thrombosis, and the indication is like anyone who is like progressive. Okay, one of the things which we can do is intra-arterial thrombectomy. Okay, not wait. I will show you. I will write over here. One of the things which we can do is called as um, intra-arterial um, thrombectomy. Okay, uh, by interventional radiology. Now, this is something which is not available everywhere. Of course, like they have very good outcomes, but of course, they need specialized uh, people with all the equipment, because this one is like you are going to remove the thrombus while going to that point. Okay, and of course, like very sophisticated things should be there to do that, right? If you found that the stroke is in from the carotids, then we can do endarterectomy. There are indications for that as well. When to do and when not to do. So that thing should be done. Uh, okay, okay. This is like the what you can say uh, things to do. Um, I'm going to put one more thing like other acute managements. Okay, which we must do in the patient or issues. Okay, so what are they? Avoid hyperglycemia. Okay. Uh, for example, if someone have febrile like fever, so control temperature. Okay. Um, Nothing peroral NPO if there is dysphagia. Why? Like because if there is dysphagia and the patient is still eating from the mouth, things can go into the respiratory tract and can cause aspiration pneumonia. So the things can become worse because of that. Okay. Uh, a very important thing, if the eyes are not closing, so eye care should be initiated as soon as possible. Eye care. So what they do, like um, if the face is affected and the eyes cannot be closed properly, so they tape the eyes. Okay, they close the eyes by tape because otherwise the eyes dry out and it can have problem with the vision. If the patient have deep venous thrombosis, so deep venous thrombosis, or even if they don't have, because the stroke patient will be bed bound for a long time, so we should start prophylaxis for DVT. Okay, uh, prophylaxis should be given for them. So this thing is important, right? Now, uh, when it comes to the hemorrhagic stroke, guys, of course, like in hemorrhagic stroke, we approach from a different way. Okay, and in that one, the most important thing is blood pressure control. Okay. Now, the bad thing is uh, you cannot leave the blood pressure like this because it can make the hemorrhage worse, or you cannot decrease the blood pressure too fast, like it can decrease the cerebral perfusion. So the first guideline to say to talk about this one is uh, do not uh, lower the BP, blood pressure, uh, unless you can say hypertension is very severe. Okay, and uh, and that's the reason basically we don't give them any antihypertensive drugs for the first 2 to 3 days or 48 to 72 hours, and that is called as permissive uh, hypertension. Okay, so why? Because like the uh, especially after thromboembolic stroke, so we don't give them any antihypertensive drug when the until the blood pressure is not more than 220 systolic or more than 120 diastolic. Okay, why? Uh, because high blood pressure shows good outcomes. It saves the brain tissue, okay, by supplying blood to the brain. And when, if needed, like if the blood pressure is more than 220 systolic or 120 diastolic, of course, we can use drugs like labetalol. So simply, this elevated blood pressure is necessary to maintain the brain perfusion to the penumbra region. Okay, that's very important. Uh, so most of the patients, who have uh, ischemic stroke, their blood pressure uh, stay elevated for 1 to 2 days. Okay, and then it comes back to like the lower values itself. Okay, lower numbers, maybe a protective mechanism of the nature. And of course, like once we have done this acute management, then we go for MRIs, we go for MRI, we go for uh, CT angiography or magnetic resonance and angiography, or you can do carotid Dopplers if you have not done. You can do cardiac examinations like echoes and all this stuff. Okay, so of course, like then, or the things to find out uh, the further what you can say causes of stroke. So one of the thing is simply, guys. Um, wait. Um, like prevention of the further stroke um, in the patients. Okay, or the primary and the secondary prevention. You can say so. Of course, like what we give these patients is like antiplatelet therapies, right? Antiplatelet therapy should be given to these patients. Uh, like antiplatelet agents, they have protective role uh, in patients. Okay, so of course we give aspirin, which is the first choice, plus clopidogrel we can give. So like that's how we manage. Okay, and now for example, someone have atrial fibrillation, so now how to deal with that. You had done atrial fibrillation, if you remember the CHAD score, CHAD, which is like completely this CHAD-VAS score. So uh, like we go based on that score, we decide either the patient needs any warfarin or any what kind of management the patient should be done. Okay, so deal with that. Deal with the cholesterol levels. If the patient cholesterol are high, so put them on statins. Control diabetes. If the patient is a smoker, um, address their smoking. Okay, ask them to follow the SNAP technique. S is for smoking, N is for nutrition, A is for activity, physical activity. Encourage them for more and more physical activity, and P is for A is for alcohol. Limit their alcohol, and P is for physical activity. So That's the important thing. Okay, like we ask these patients to do. And rest, like in next semester, what you are going to do one subject called as rehabilitation. So in that one, you will learn a lot about the stroke rehabilitation. So uh, most of the stroke patients, of course, uh, once they are acutely managed, and like we already find out the cause of the stroke, and we are preventing that, we are controlling that, and all this stuff. Then of course, like we refer them to the rehabilitation department, and uh, what they do, like rehabilitation. There is MDT or multidisciplinary teams made up of speech therapists, physiotherapists, orthotics, prosthetics, all these people, occupational therapists, all these people, uh, they are the one who rehabilitate them. The speech therapist, if there is any dysphasia or any problem like this, so they do like rehabilitation for their communication. They assess their cognitive and psychological assessment. Uh, they rehabilitate if they have depression. They give them exercise programs. They assess like how much they can ambulate or move around, and then they can give them some assistive devices or splints or braces, and all this thing, of course, should be done. So uh, that's all. Basically, okay, I did not talk about subarachnoid hemorrhage. I did not talk about extradural hemorrhage or subdural hemorrhage or intracerebral hemorrhage I talk about. Okay, so I did not talk about subarachnoid hemorrhage, extradural and subdural uh, hemorrhage. Okay, these three types, because these are more like the topics of neurosurgery or the surgery. In surgery, like they are going to teach you, or maybe they already teach you. If they did not talk about that in surgery, so of course, like I can make one video for that as well. So anyhow, guys, thank you for listening. So of course, like the last part should be is like uh, rehabilitation or stroke rehabilitation. Of course, like in the next semester, you are going to read this thing in detail. So stroke rehabilitation uh, should be should be initiated um, at the earliest, because they have like good outcomes when they are initiated earlier. The outcome is better. So thank you so much, guys, for listening to this lecture. Hope you understand. I'll see you around.